Thank you. It's a privilege to be able to share my morning with you. So thank you for inviting me back-to-back appearances. So I'm going to be talking to you about National Pharmacare and really starting back at the beginning of this. So for those of you who are really deep in this file, you might find these introductory slides a little bit flat, but I recognize not all of us are kind of living and breathing Pharmacare in the same way today. So we heard yesterday about how much our history has shaped where we are today. So I just wanted to start by reminding us sort of where we all start in a legislative framework for our healthcare system. So back when Canada became a country in the mid-1800s with the establishment of us through the British North American Act, that is where we split out healthcare to be a provincial responsibility. So this really dates all the way back to our roots as a country and has not changed in over 100 years. The second big piece is, of course, the Medicare Act in the 60s, which has explicit language around doctors and hospitals and defines our healthcare system in that very narrow way, with things offered in a hospital and delivered by physicians being within our healthcare system and must be publicly provided. Of course, the big change to that was the Canada Health Act, where we prohibit user charges still in hospitals and with doctors and physician services. So nowhere in any of this is there explicit language about pharmaceuticals or drugs being offered or covered within a public system. So where has that led us to today? Some describe our system of drug insurance as a huge patchwork quilt. So we have 19 federal, provincial, territorial, publicly funded drug insurance systems and a huge variety of private insurance in addition to that. About 60% of Canadians do have private insurance, and most of that, as you can imagine, is related to your employment status. When we think about the publicly funded plans, we again have 19 sort of insurers, if you will, and underneath that, a huge variety of specific plans. So I've highlighted 3 different provinces here for you, BC on the far left, Alberta in the middle, and Ontario. And in that little table, you'll see that there's 10 plans in action in Alberta, and I'll highlight that because that's where I have the most familiarity. And these plans include something specific for social assistance, those who are under 65, those who are over 65, as well as specialized plans for example, palliative care, cancer drugs, high-cost drugs that are not cancer drugs, children who are in families that are above the income threshold for social assistance but are still in financial need. So a huge kind of mishmash of different plans, but in their entirety do have a plan that would be available to anyone in the province, although albeit some of those plans do have premiums. So when you put together these big patchworks, what you do see is that actually everybody in Canada does have some kind of publicly funded plan that they could either buy into if there is a premium or access without a premium. All of these plans do band together to negotiate price in the Pan-Canadian Pharmaceutical Alliance, and the private insurers are not included in that. So we do have a market that is sort of consolidated across the public plans already, So when we look at that picture from a financial perspective, we are spending just under $40 billion in 2019, and of that, we have about 42% of that is public expenditures. So a per capita expenditure of total of about $909, and of that, $388 is a public expenditure per capita. And of course that varies a little bit when you look at it by province, but the provinces are generally between kind of 37 and 43%. This 42.7% is the overall Canadian picture. Of that, the remaining expense, about 22% of this expenditure is direct out-of-pocket expenditures from patients, and the rest is presumably private insurance. We don't have a good handle on the non-publicly funded components and what's driving it. So when we think about this in terms of affordability, we do know that 5.5% of Canadians report being unable to afford at least one medication in the last year. And so this comes from national data from the Canadian Community Health Survey, where the questions ask about people having skipped, stretched, or simply not filled prescriptions due to financial hardship. One important point here is that often this statistic is conflated with insurance statistics. So we think about 8% of Canadians are uninsured. And what we forget when we talk about that is, particularly in a province like Alberta, for example, where you have a premium to buy into the public plan if you wish, some people rationally uninsure. They're well, they're not using any medications, there's no reason for them to pay a premium for an optional insurance. If they were to get sick, they could pay the premium and receive insurance in a very quick manner. So there is definitely a rational uninsured group. And when we think about insurance, we do know that 3.4% of people with insurance report being unable to afford their medications. So I think it's very important that we separate insurance status from affordability, and in my opinion, we really need to focus on the affordability aspect. So there's been a flurry of conversations over the last 5 years, I would say, and this really is the first flurry of political conversations that have been real and tangible since our last big one in 2008, which resulted in the National Pharmaceutical Strategy, which was unfortunately not advanced at the federal level due to a change in government, but many of those components were advanced in the pan-provincial alliances. So in 2018, there was the establishment of the Advisory Council on the Implementation of National Pharmacare, and they did a lot of work. They did a grand listening tour, spoke to many Canadians, people in government and other agencies, and what resulted was a recommendation of a plan that would look like Medicare, so have the same kind of 5 basic tenets that are available in Medicare, and they put out a plan that would see full implementation of this plan by 2027. So quite a long leadway here. And what it sort of looked like was that they would begin negotiating and bringing the provinces and territories on board, because of course this does remain provincial jurisdiction, and they would have everywhere on board and legislation ready to table in 2022. The second purple line speaks about the Canadian Drug Agency, which would again be established and in full working order by 2027. And this is an agency that would be tasked with developing a national formulary, making decisions on drugs based on clinical effectiveness as well as cost effectiveness. And they would also be responsible for sort of offering guidance and setting out prescription guidelines. Alongside this, we would also have a national formulary, of course, because not every single drug would be covered by this plan. It would start with an essential medicines list, so a list of drugs that are perhaps most commonly prescribed, and there's a list from the World Health Organization that lists out kind of drugs that should be covered just for basic human rights that are included. So we would start with this list and grow it to something more comprehensive again over this 10-year window. And then alongside all of this, recognizing that rare diseases are very challenging for a system like this, they would develop a national rare disease strategy that is distinct from the existing plan, probably working in concert somehow, but that dealt with those rare diseases which often have very expensive drugs and therapies available. In total in this report, there's over 60 recommendations, and the final sort of plan design that they come up with is that it would be universal health coverage, essentially, starting at essential medicines, so that shortened comprehensive list, with a $2 copay for the essential medicines, with some groups having no copay at all, so those on social assistance primarily, and then a $5 copay for all other drugs that are not on the essential medicines list. So after that got tabled, we very quickly went into election mode. And in the fall 2019 mandate letter to the Federal Minister of Health, there's a lot of words on that slide, but this is a quote taken directly out of the mandate letter to the Minister of Health in play at the moment, where she has been tasked to lead work with the support of those around her. And the fourth point and priority area is around continuing to implement national universal pharmacare, including the establishment of the Canada Drug Agency. I will note that this language is quite vague. It does not say implement the recommendations of the National Advisory Council. And so this still gives us quite a lot of room and flexibility to be thinking about, well, what does national pharmacare actually mean? and what are the specific elements of a plan that would be required to move forward here. So that's where we're at the moment. Now I want to kind of turn over to a little bit of a critique and share some of my thoughts about where we could expect to go in the next little while. Uh-oh, I broke it. Oh, sorry. So I think fundamentally we need to step back from this and really think about what we are trying to achieve here. Again, we heard yesterday about how much of what we focus on is a historical perspective on what we already have. And I think we use words like universal, perhaps because we're so used to saying those words, without really critically thinking about what we're trying to achieve when we say we want universal pharmacare. And just to kind of put some terms around that, when we think about universality in terms of the Canada Health Act, it is defined as a uniform set of terms and conditions that apply to every person in Canada. And so in that, for example, we have no point of pay coverage for every Canadian for services within a hospital and offered by physicians. So uniform terms and conditions for everybody. Others have used universality to really define a set of public policies that provide everyone with some form of coverage. Not necessarily the same coverage, but that everybody does have coverage. And when we look at what the Advisory Council put forward, they used universality to mean something that really translates to a system of health insurance plans that do provide people with access to necessary medications. So the other thing I think we need to think about here is equity. And when we're starting from a system of known inequalities within our system, there are people that can access their medicines and people that can't. When we think about universality, does it make sense to overlay something that is the same for every Canadian, recognizing that we already have inequalities in our population? And perhaps we want to be thinking about addressing those inequities as a priority and accepting that that means that not everybody will be treated equally with this plan. So if we are willing to step back a little bit from kind of universal terms and conditions for every Canadian, then we can really open up this conversation to have three different questions that we need to answer. Who is going to be covered by this plan? What will be covered? What medications will be covered? And how should cost be shared? And I want to just spend a moment on this last question about how should cost be shared, because we heard yesterday from Sarah that we've really normalized cost sharing in drugs and outpatient medications in a way that we have not normalized copays for other necessary medical services. We don't copay for doctors, we don't copay for the hospitals here, but somehow every single country in the OECD does have copayment and cost-sharing mechanisms for their outpatient drugs. We've really normalized it, and so we haven't even considered that the answer to this question could be, well, we don't cost share this way, we cost share through our tax payments. We know very little about the effects of cost sharing. In a recent systematic review, there were only 7 studies that looked at the effects on drug utilization of different cost sharing mechanisms. And what they found in general, albeit a weak conclusion, is that generally small amounts of cost sharing do not affect utilization in a general population. But there are, of course, segments of that population for whom very small copays do decrease their utilization of necessary medicines, and it wouldn't surprise you to know that that population is generally those with a lower income. Some other recent data out of Canada has demonstrated that about people who have an expenditure of about 5% of their income on their outpatient drugs are 3 times more likely to experience cost-related non-adherence. So there is definitely space to have a copay for some portion of the population that does not affect your utilization, but we need to be very thoughtful about how that cost sharing is incorporated into a plan. So when tasked with this broader question, I had the privilege of working with the infamous Mike Law to think about different ways we could move forward. And we came up with 2 different models, and within those kind of 5 different design plan options that you could think about. So really, there is an approach of universal public coverage, meaning the same, so everybody is in, all Canadians are in. Or you could think about a more targeted public coverage plan where you have public insurance either mandated or available for different proportions of the Canadian population. Within the universal public coverage plan, you could think about something that is comprehensive, which is where most of us would go when we think about a kind of universal plan. Everybody is in, it's fully covered for all drugs, and no cost sharing would be our ideal here. But then, of course, reality would set in at a certain time with that. So you could also think about an essential medicines list. So again, a smaller list of drugs that are covered for everybody. Or you could think about something that is an income-based deductible kind of plan. So here you would have some kind of a sliding scale where different people would have different support levels and probably different co-payment levels with, that varied with their income. If you were to think about a more targeted public coverage plan, one thing you could think about here would be an individual mandate. So we would legislate that everybody must have insurance. It would be up to the person whether they chose to have a public insurance plan or a private insurance plan. And we see this model in Quebec. And then you would have to have strict regulations about what the minimum requirements of a private insurance plan would be, and also a mechanism to ensure that there was an option for people who could not or were unable to get private insurance. We did hear yesterday a lot from Sarah about how institutionalizing private health insurance can be extremely problematic, and I think that's an important consideration when we think about these kind of targeted public coverage models, is that you are essentially embedding a necessary role for private insurance for the foreseeable future. And based on the stasis that we've seen in Canadian health insurance, in Canadian health policy, I think we should really think about that institutionalization in sort of 100-year periods as opposed to shorter time windows. And then, of course, the last option here is just a targeted plan where you have a fully public available option that is available for people who wish to insure in this way. You don't mandate it. You can have drug insurance if you wish, and we have an option should you choose to take advantage of it. So how could you think about these different models and how could you critique them? There are, I think, 3 essential questions for us to think about as we think about the pros and cons of these different models. Aim 1 would be improving access to medicines. Does this plan advance us from where we are today? And here we're really thinking about the ability to fill medically necessary prescriptions without experiencing financial hardship. So here we're talking about really this being based on medical need, not the ability to pay. We would think about improving value for money. And here again, we're thinking about, are we getting good value for the investment of public funds required? And here we would think about things like clinical outcomes or clinical effectiveness. We'd also want to think about effective stewardship of our resources. Are we getting reasonable payback for the investment we're making? And concerns of fiscal sustainability over the long term. Lastly, are we improving the patient and provider experience? I think ideally we would want a system that is simple, easy to navigate for people, limited administrative burden for both the patient and the providers, and clear coverage details so that people understood the details and the coverage that they did have. Just as a side note here, there are many, many other things that you would want to consider that I think you could deal with in a different regulatory framework than the insurance design itself. So for example, how are new drugs being brought to the market? How are we able to negotiate on price for these drugs? How do we take drugs off the formulary? And how do we negotiate sort of longer term investment here? I think all those things are very important parts of this conversation, but don't need to be dealt with within the design of an insurance system. So I'm just going to take you through sort of the 2 models that are on the table right now. So the first is a completely public comprehensive plan. And so when you think about this sort of infographic that you see in front of you, we just developed this to give you a quick snapshot of who would be covered, what would be covered, and how the copay would be designed. So if we were to do something like this, we most certainly would see an improvement in access to medicines. People who are experiencing issues with the affordability of their medicine right now would most certainly be benefited under a model that is completely a publicly funded model. Of course, this would be tightly linked to the copay, so it would be very important for us to think about how we designed that cost-sharing piece across different segments of the population. We would see a decline in private insurance. This would essentially crowd out any of the private insurance models that are really based on drug coverage and other parts of the population coverage right now. And this may affect our ability to be competitive in different things, whereas right now, insurance plans and benefits are used as a very attractive way to differentiate between jobs in the market for people. And so we would definitely see a decrease in the ability to do that. We would see a shift of private spending over to the public sector, and guesstimates of these numbers are about $19.3 billion annually for a plan like this, and of that, about $12 billion would be offset expenditures that are currently expended in the private system. We would probably have larger negotiating power if we had a market like this. But given that the provinces and the federal territories are already banding together to negotiate, and that we already have long-term negotiated deals in place for segments of the market, like generics, for example, it's not entirely clear in the short term how much better we would be able to do on our pricing and our drug budget here. Obviously, it would be much simpler for a patient perspective. Everyone would have the exact same coverage. Hopefully, we'd be able to design something that was very easy for patients to navigate, but this would be incredibly disruptive to our already existing sector. The other thing that's on the table right now through the National Advisory Council is starting with the essential medicines list and having a more comprehensive public plan that covers 125 medicines off the get-go. Of note, this covers about 44% of all prescriptions. And if you think about class equivalents for the medications that are explicitly named on the list, probably more. We could probably get that percentage up to about 70. So on the flip side of that, that does mean that there's probably about 30% of prescriptions that are being filled that would not fit within this list. So not an insignificant problem. And I think we need to be thoughtful about the equity and inequities that we would be introducing when we prioritized funding for certain diseases over other diseases. I think if we were to move to a model like this, we would very quickly need to be thinking about how to move to a more comprehensive model that included more drugs, and we would need to have that plan of action committed to and a timeline to advance it very quickly. Private insurance would still have a place here, much more so than comprehensive public coverage, because of course there would be this group of patients that still did not have coverage for their medications. And we guesstimate the price tag of this to be about $3.5 billion in 2022 once the implementation was rolled out, according to the Advisory Council. For a patient, I think this could be quite a complicated system for you to understand which medications are on the list, which medications are off the list, what do I do if I switch between them, and I think this could be a reasonably burdensome model. The disruption here would be not as much as a fully comprehensive public model, but I think we would also experience some disruption in the system. So where are we today? So about 2.5–3 weeks ago, the Canada Pharmacare Act was brought forward in the federal House by an NDP member. And in this, they do map out basically the same kinds of tenets as we see in Medicare. So there's the 5 tenets are also seen here in terms of public administration, universality, portability, accessibility, and comprehensiveness. Of note, when they say comprehensiveness, they do mean complete, full first dollar coverage of medications, including dispensing fees, so even more broadly than you might have conceptualized comprehensiveness at first. And when they speak about universality, they're explicit that they mean insurance for all persons under uniform terms and conditions, so no variation in coverage for any Canadian. And for meeting these criteria, there would be a cash transfer to the provinces to be able to operate their drug insurance plan. So almost certainly, we will see a conversation at the federal level of this bill as it's debated and read in the House, which I'm very excited to follow along with. And just in closing, I'd like to share with you the quote in response from Minister Hajdu, who is our current federal minister. And this is what she said in response to the tabling of the Canada Pharmacare Act. So whether we are indeed at a rolling stone or we are about to become a mossy boulder again, I am not sure. This quote is pretty vague and non-committal. So I think in the next 2 to 3 weeks, we will sort of see what happens here and which side of that we are on. So thank you very much.